Thank you very much. Good afternoon, and thank you very much for the invitation. I'd like to speak briefly on hip fracture history and the experience of the last 15 years in the Royal Victoria Hospital, which is the regional trauma centre in Northern Ireland. The Royal Victoria Hospital in Belfast operates on over 800 hip fractures every year, and the Fracture Outcomes Research Database was set up about 16 years ago for collection of inpatient fracture data. We were identified as an outlier in 2014 due to our low 30-day mortality rates by the NHFD. We have a crude 30-day mortality rate of 4.4% and an adjusted rate of 3.9%. This has been independently verified by the Business Services Organisation. So why have mortality rates been low and gradually improving? Well, if you look at the demographics, the patients certainly aren't getting any younger. 60% of our patients are now aged 80 and over. They're certainly not getting any healthier. 58% of them, as shown in green, are ASA 3. There's been a marked rise in ASA 4 patients who now represent 26% of all our hip fractures. Our most common operations are hemiarthroplasty, shown in green, and DHS in red, but there's been quite a rise in total hip replacement and IM nails, as shown in purple and blue at the top. So the operations we're doing aren't getting any simpler. But we have tried to progressively improve evidence-based guidance and our compliance with that, such as use of the NICE guidelines. So now about 3/4 of spaced intercapsular hip fractures are treated with cemented hemiarthroplasty, as shown in green, and a rate of total hip replacement for eligible patients is very close to the NHFD average. Essentially, all hemiarthroplasty and total hip replacement is done with cementing, with routine implementation of the AAGBI recommendations for safer cementing. About 3/4 of simple extracapsular fractures are treated with the DHS, as shown in blue, and most of the rest are treated with IM nails. IM nails in red are now used for almost all subtrochanteric hip fractures. So we now have good compliance with a number of the NICE recommendations, but time to theatre remains an issue, although it has been improving. On average, patients now wait about 2 days for hip fracture surgery, and about 1/6 of that time is waiting for admission to the Royal Victoria. Now, Northern Ireland doesn't have the best practice tariff. It has a 48-hour target from the Department of Health, but if you look at 36 hours as being more comparable to what the NHFD would recommend, we found that even in 2015, only 45% of hip fracture patients got surgery within 36 hours. Mortality rates for the first 30 days and for a year have been gradually improving over a number of years. But the mortality rates during the first month and the next 3 actually show very poor correlation, implying that once patients are discharged to the community, we have very little power over the level of ongoing medical care there. The highest rate of 30-day mortality is in the very small number of patients who we can't medically optimise enough to get to theatre, as shown in orange. But if you met those, you can see that for all SA grades, the mortality rates have been quite low. Shown a different way, risk of 30-day mortality increases with increasing ASA, as you'd expect, but recent results have been improved in comparison to the average since 2000. Now, while we are striving to improve waiting times, and we don't for a moment condone delays, we did observe that patients who had to wait for more than 36 hours actually had a better 30-day survival rate than those operated on within 36 hours. This is difficult to explain, but we think it's probably due to our high level of orthophysician care. In fact, we think our key strength is our multidisciplinary teamwork in the best interest of each patient. So in conclusion, we have low 30-day mortality rates despite delays to theatre. We think this is probably due to rationalisation of treatment according to evidence and guidelines, high level of orthophysician input, and multidisciplinary team cooperation. Thank you very much indeed.
Julie, comments for Julie. That I think she was obviously inviting the question, wasn't she? What's your thoughts? You guys in England have got these targets to go for. Scotland, we've got targets as well, but we're failing ours badly. At least in Aberdeen we are. Omar.
Thank you, Julie. That was brilliant. Did you have a look at the number of patients requiring total hip replacement and whether those had to wait any longer for a specialist hip surgeon to do the operation?
We didn't specifically look at time to theatre for toe hip replacement. Broadly speaking, in our unit, it's not a problem. Of the 16 non-spinal surgeons, about 8 of those are happy to do the total hip replacement. Wow. And we have 3 to 5 operating lists per day. So you will have somebody happy to do total hip most days of the week. If not that, then the next day. So that's not a big issue for our department.
8 out of 16 surgeons happy to do total hip replacement for a neck of femur.
Yes.
That's pretty remarkable. Thank you.
Julie, just say well done. I mean, that mortality figures are staggeringly good. So congratulations, and we've got a lot to learn from you about that, because I think that's half, isn't it, the adjusted figure of 3.9 of what we are at the moment in England. You presented a lot of data there about the factors that may affect it, the nice guidance and adoption of that and so on. For you, though, what's the single biggest factor that separates Belfast from the rest of us?
A friend met me in the corridor and said that if I had 4 minutes, just put up a picture of Gary Hayburn and leave it there for 4 minutes. Our ortho-geriatricians, or I really should say ortho-physicians, because they're more like intensivists, more like acute physicians. They really are our saving grace. And I think that's what makes our model work and what maybe differentiates us from other units. So I, as a surgeon, I think I can take really the majority of the credit for what we're doing surgically, because what we're doing surgically is in keeping with national guidelines, but this is something which I think we felt on the ground, and we now have some data to prove that.
Thank you.
There you go.
So, just on the topic of orthogeriatricians, are the patients admitted under the orthogeriatricians primarily, and you operate and leave them in their care, or is it the other way around? Are they admitted under orthopedic surgeons or geriatricians?
So, they are admitted purely under orthopaedics, but we have an in-house ortho-physician team. Okay. So they're shared care in everything but name. So our ortho-physicians have their offices on the orthopaedic ward. They come to the trauma meetings. They are on the ward all the time. They are omnipresent. They don't go off to any other, geriatric unit. They live with us.
So one quick sort of technical issue. You said about pressurizing cement. You said gentle pressurization. What is that about your slide on cementation? You said there was a point about gentle pressurization. It's quite topical in our hospital, you see cementation. So if you just elaborate on that, what, just finger packing or?
Yeah, rule of thumb pressure. We don't do the type of pressurization that you would do for total hip replacement, for example. It's something we don't do. We use extra stems, but we don't do high level pressurization because of the patient population.
One more question. Oh, sorry. 2 more questions.
What grade have your orthogeriatricians got? Are they just the consultants coming there to visit, or are they sort of registrars or even house officers?
We have 1 consultant. We have, at different times over the last few years, between 2 and 4 staff grade, trust grade specialty doctors. They also have a team of medical foundation doctors as part of their foundation rotation, and all the F1s on the ward are medical F1s. So they are essentially a substantive medical team that are on the ward with good supervision.
Thanks.
They don't have any other responsibilities. The geriatrics are not looking after anybody else.
Yeah.
It's a different form of question, because we tend to look at all of this data and seek for a medical reason for it. But as Mike has pointed out, that the Northern Irish are different. Now, actually, what I'm really asking is, have you got any evidence that the social infrastructure that support patients as they are discharged is different in Northern Ireland to the rest of England? Might be the same in Wales, might be the same in Scotland. But it's one of the factors that we don't necessarily measure in this. We talk about all the medical factors, but maybe we're talking about the social infrastructure that support people.
I think if I was going to say about how the hip fractures in Northern Ireland differ from the rest, you can see how our crude rate and our adjusted rate demonstrate that our patients are pretty sick. They're sicker than the average. So they're old, they're sick, and they're getting the same operations you would do. There's an ongoing debate, I think, as to the value of looking at 120-day mortality rates. We focus on 30-day mortality because, as I say, once they go to the community, the next 3 months after that, you're looking at GPs you know, as a surgeon can't influence how their GPs look after them. So that's a question in itself, and you could probably talk all day about super spell. I don't have any evidence as to social structure, but I know the caliber of patient that comes through our door, and they are sick. But my feeling is that longer term outcomes such as 1 year survival and, you know, 1 year mobility, functional outcomes, things like that, the first stage to surviving a year is surviving the first month. So if you're going to not get through the first 30 days, you're not going to get to a year. So as a small unit, we have to think about what we can do. I can't change the GPs in the nursing homes, so we have to focus on what we can do in-house. In direct answer to your question, I don't have evidence on that. I'm sure somebody does. Chris,
a quick question.
Just a quick one. Have you tested the Gary effect? He is fantastic. Your results are fantastic. If you've been going for 10 years now, he's had 6 weeks holiday a year. That's 60 weeks when he's not been there. Is the mortality different when you don't have a consultant physician leading the team?
Well, we've looked at actually the weekend effect. You know, is there an issue when you don't have the ortho physicians there Saturday and Sunday? It doesn't seem to make a big impact, and the point of that is that even down at the most junior level, they are drilled in the ways of Hayburn, so they're all brought up knowing how to deal with all these commonly occurring major medical problems that all these patients have. So it's not like there's a them and us among the medical people. It's that they all work together as a team. The F1s are at the X-ray meeting with the orthogeriatric consultant.
So he's introduced a system, and we need to learn from that system. Thank you.
Good, I'll stop you there. Thanks very much.
Thank you
Julie.
very much.